Bismillahirrahmanirrahim. Today we will have case quiz number 60, and this is the first time to record from my new office. Case data: 22 years old male, complaining of swelling of the third BIB joint of the right hand for the last 2.5 years. In fact, the patient have symmetrical swelling on the BIB proximal interphalangeal joint of the digits 3 and 4 bilaterally, but the main complaint is in the third BIB of the right side. The patient was previously diagnosed in another medical center as rheumatoid arthritis and received methotrexate, but the patient discontinued the treatment on his own as no benefit was obtained. The patient have no pain in the joint, so painless swelling of the joints with no morning stiffness and no night pains. On examination, the systemic examination was unremarkable. Joint swelling in the fourth and more evidently in the third BIB joint of the right hand and on the third and the fourth BIBs of the left hand. So the third and the fourth BIBs bilateral were swollen, but the most prominent is in the third right BIB, with no tenderness and full range of motion. Investigations revealed CBC, liver function test, kidney function test, erythrocyte sedimentation rate, C-reactive protein, thyroid function test, and urine analysis were all normal. Hepatitis markers, ANA, rheumatoid factor, anti-CCP antibodies were negative. X-ray showed periarticular soft tissue swelling, but no sclerosis, joint space narrowing, erosions, or periosteal reaction, with no evidence of BIB joint inflammation on musculoskeletal ultrasound examination. Thickening of the subcutaneous tissue was detected on MRI, but no evidence could be associated with synovitis. So, what is the most probable diagnosis? This is the first question, and the second question is, what is the missed investigation here needed for diagnosis or exclusion of this probable diagnosis? The answer of the first question is, it is a very rare case. It is Brachydermodactyly, BDD. This is the first answer. And the second answer regarding the needed investigation, it is biopsy, skin and soft tissue biopsy. Biopsy is needed for investigation for diagnosis for BDD syndrome. A biopsy was performed from the lateral aspect of the third BIB joint of the right hand with preliminary diagnosis of BDD, and hyperkeratosis and thickened dermis with collagen deposition were detected. The patient was diagnosed with BDD after evaluation for clinical laboratory radiology and biopsy findings. The patient was given information that BDD is non-inflammatory disease with a benign course. Here the hands of the patient. This figure shows photographic imaging of bilateral hands showing symmetrical swelling. Symmetrical swelling of the third and the fourth BIBs, especially in the third BIB of the right side, but painless with full range of motion. The second figure showing hand radiograph showing soft tissue swelling around the proximal interphalangeal joints BIB without joint narrowing or bony erosions. Here the soft tissue swelling here and here. The third figure showing magnetic resonance imaging MRI reveals soft tissue swelling of the third to fourth proximal interphalangeal joints of the hand without articular or bony abnormalities. And the last figure shows skin biopsy specimen exhibit marked hyperkeratosis and thickened dermis with collagen deposition. So, what is pachydermodactyly? What is pachydermodactyly? BDD is a rare digital fibromatosis first reported by Bassex et al. In 1973, around 50 years ago, and was then named BDD by Verbov in 1975. Up to date, approximately 150 cases were recorded all over the world. So it is a very rare syndrome. It is characterized by soft tissue swelling, especially in the lateral part of the BIB joint of the second two-fourths fingers of adolescent males. Adolescent males. It is approximately 4 times more common in males compared to females. There are also familial cases as case reports in the literatures. Although the etiology is not fully understood, mechanical trauma is precipitating factor in 44% of the patient. Near half of the patient have previous history of mechanical trauma. Continuous pulling and docking of the finger can be seen in some occupations such as athletes, musicians, computer users, farm workers, and also in subjects with Asperger syndrome and obsessive compulsive disorders. Therefore, a psychiatric consultation is essential when the BDD syndrome is suspicious or diagnosed. Bardazzi et al. Defined BDD in 5 subtypes. The first is classical, which affect multiple joints and it is due to repeated microtrauma. The second type is localized, which affect only one joint. The third type is transgradient, which affect the dorsum of the hand and MCB areas rather than the BIBs. The fourth type is the familial, which runs in families and may have environmental sharing or genetic background. And the last type is the form associated with tuberous sclerosis. There is no specific laboratory findings for the diagnosis. The acute phase proteins are normal and there are no specific autoantibodies for the disease. No periarticular osteoporosis, periosteal reaction, erosion, osteophyte or cyst are observed on radiographs, only soft tissue swelling. No pathological findings such as synovitis, capsulitis, tendinitis, or hypervascularization apart from soft tissue swelling are found on MRI screening. In histopathological examination, BDD is characterized by hyperkeratosis and acanthosis in the epidermis and thick collagen bundles and increased fibroblasts in the dermis. The cytological appearance of the fibroblast is benign. There may be also mucin accumulation in the interstitium in varying degrees and the number of elastic fibers may be decreased. When collagen analysis is performed, the amount of collagen type 3 and 5 is higher than normal. Collagen fibers are less uniform and of smaller diameter in electron Chen et al. Proposed the diagnostic criteria of no symptoms of the patient, no morning stiffness, no pain with movement, and tenderness with palpation, finger swelling especially on the ulnar and radial side but not peripheral, normal laboratory tests, and only soft tissue swellings on the X-ray. In the differential diagnosis, there should be consideration of rheumatological diseases such as GIA, if before 16 years, or rheumatoid arthritis if after 16 years of age, bone disease such as spina ventosa and pachydermoperiostosis. Also skin disease such as knuckle pads and foreign body granuloma and genetic causes such as Simon's disease. All of these may be differential diagnosis of BDD syndrome. Regarding treatment, there is no universally accepted treatment options. It may be useful to avoid mechanical stimulation as mechanical trauma may be the most predisposition for this case. Some cases improved with oral tranilast, intralesional triamcinolone injection, and surgical excision of the fibrotic tissues. Tranilast is an anti-allergic drug which inhibits collagen synthesis. Regarding this specific case, no treatment was applied to the current patient, but he had a habit of pulling his fingers. He was advised to discontinue this habit and the patient was referred to the psychiatric clinic for consultation. This is a true case, not just arbitrary case quiz. And if you request, I can send you the paper including this case record. The key points here are pachydermodactyly is a rare benign disease. As it causes swelling in the PIB joints, the differential diagnosis must consider rheumatological diseases and primarily, of course, rheumatoid arthritis. But preserved function with no restricted range of motion, no morning stiffness, and no pathology determined with laboratory and imaging methods are significant characteristics for these cases. The correct recognition of BDD prevent unnecessary referrals and tests, and most importantly, unneeded inappropriate treatment. So these patients will not benefit from methotrexate, anti-inflammatory steroid, and so on, because this is a benign and non-inflammatory condition. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 61. Wassalamu alaikum wa rahmatullahi wa barakatuh.